Mycoplasma genitalium infection is a sexually transmitted disease caused by an exceptionally small bacterium that lacks a rigid cell wall, which allows it to squeeze through the mucosal surfaces of the genital tract. Because the organism is so diminutive, about 0.2 to 0.3 micrometers in diameter, it often goes unnoticed by the immune system, resulting in mild or completely asymptomatic infections in many individuals. The infection can persist for weeks to months, acting as a silent reservoir that facilitates transmission to new partners. In clinical practice, the infection is frequently identified only when patients undergo nucleic acid-based testing for other STIs, or when they develop complications such as urethritis, cervicitis, or pelvic inflammatory disease. The sole etiologic agent of this infection is Mycoplasma genitalium, a bacterium that spreads primarily through unprotected sexual contact, vaginal, anal, or oral. The organism adheres to epithelial cells using specialized surface proteins P140, P110 that act like tiny grappling hooks, enabling it to hitch a ride from one partner to another during close mucosal contact. Transmission risk increases with number of sexual partners, inconsistent condom use, and the presence of other ulcerative STIs such as herpes simplex virus, which can disrupt the mucosal barrier and create entry points for the bacterium. After deposition on the genital mucosa, M. genitalium uses its adhesins to anchor to the urethral or cervical epithelium. It then secretes a suite of cytotoxic proteins, including the MGP, a operon-encoded proteins and extracellular nuclease that act like microscopic drills, creating microerosions in the cell membrane. These breaches trigger an innate immune response characterized by neutrophil infiltration, cytokine release, IL-1 beta, IL-6, TNF-alpha, and localized inflammation. In women, the inflammatory cascade can ascend to the upper genital tract, producing cervicitis or pelvic inflammatory disease. In men, the response manifests as non-gonococcal urethritis with characteristic burning and discharge. Mycoplasma genitalium has a worldwide distribution, with prevalence estimates ranging from 0.5% to 2% among sexually active individuals in high-income nations and up to 5% in some low-resource settings. The highest burden is observed in people aged 15 to 35, especially those with multiple concurrent partners, men who have sex with men, MSM, and individuals who do not regularly use barrier protection. Studies using nucleic acid amplification tests, NAATs, have shown that prevalence is relatively stable over time, but that antimicrobial resistance, particularly to macrolides and fluoroquinolones, has risen sharply, complicating treatment algorithms. Clinical presentation varies widely. In men, the most common manifestation is non-gonococcal urethritis, characterized by dysuria, a clear or mucoid urethral discharge, and occasional glands irritation. Women may experience cervicitis with mucopurulent discharge, intermenstrual spotting, or pelvic pain that mimics other STIs. Approximately 30 to 50% of infected individuals remain completely asymptomatic, acting as silent carriers and contributing to ongoing transmission. When symptoms do appear, they are often mild enough to be mistaken for urinary tract infection or vaginitis, underscoring the need for targeted laboratory testing. The gold standard for diagnosing M. genitalium infection is nucleic acid amplification testing, most commonly polymerase chain reaction, performed on first catch urine for men or endocervical or vaginal swabs for women. These assays detect the organism's specific DNA sequences with a sensitivity of 85 to 95% and specificity greater than 95%. Because the bacterium is difficult to culture, culture-based methods are rarely used in clinical settings. Some laboratories also offer resistance-guided testing that identifies macrolide resistance mutations, for example 23srRNA, to inform antibiotic selection before treatment begins. While M. genitalium does not have formal subspecies, infections are clinically categorized based on the anatomical site and severity. The primary classifications are urethritis, infection confined to the male urethra, presenting with dysuria and discharge. Cervicitis, inflammation of the cervical epithelium in women, often accompanied by mucopurulent discharge. Pelvic inflammatory disease, PID, when the infection ascends from the cervix to the upper genital tract, causing tubal inflammation, adhesions, and risk of infertility. These categories guide clinicians in selecting appropriate diagnostic specimens and in anticipating possible complications. First-line therapy historically consisted of a single 1-gram dose of azithromycin, but rising macrolide resistance, up to 40% in some regions, has lowered its efficacy. Current guidelines recommend a test and treat approach. Obtain a specimen for NAAT with resistance testing, then prescribe a 5-day azithromycin regimen 500 mg on day 1, then 250 mg daily only if the strain is susceptible. For macrolide-resistant infections, a 7-day course of moxifloxacin 400 mg daily is recommended, though fluoroquinolone resistance is also emerging. Alternative agents under investigation include doxycycline as a suppressive therapy and newer agents such as lefamulin. All sexual partners within the past 60 days should receive concurrent treatment to prevent reinfection, and patients must complete the full course even if symptoms resolve early. Preventive strategies focus on reducing exposure to the organism. Consistent and correct condom use, male or female, dramatically lowers transmission risk by creating a physical barrier that blocks the bacterium's passage. Limiting the number of concurrent sexual partners and fostering open communication about STI testing further curtails spread. Routine screening for M. genitalium in high-risk groups, such as MSM, sex workers, and individuals with a history of recurrent non-gonococcal urethritis, allows for early detection and treatment, breaking the chain of infection. Public health campaigns that educate about asymptomatic carriage and the importance of partner notification are also essential components of prevention. When identified and treated promptly with an effective antibiotic regimen, the prognosis for M. genitalium infection is excellent. Most patients experience complete symptom resolution within 1 to 2 weeks and have no lasting sequelae. However, untreated or inadequately treated infections can progress to chronic urethritis, cervicitis, or PID, increasing the risk of infertility, ectopic pregnancy, and chronic pelvic pain. Reinfection rates are relatively high if sexual partners are not simultaneously treated. In immunocompromised patients, the infection may be more persistent and harder to eradicate, highlighting the need for vigilant follow-up and possibly extended therapy. Recent investigations have focused on 2 major fronts: novel antimicrobial agents and rapid diagnostics. Lefamulin, a pleurimutulin antibiotic, has shown in vitro potency against macrolide and fluoroquinolone-resistant M. genitalium strains, and early phase 2 trials suggest a favorable safety profile. Concurrently, point-of-care NAAT platforms capable of delivering results in under 60 minutes are being piloted in community clinics, enabling same-day treatment decisions. Another area of active research is the use of whole genome sequencing to map resistance-conferring mutations, which may soon inform precision medicine algorithms that tailor